Yeah, good evening. Look, my name is Paul Grant. My topic is shoulder dystocia and the management and treatment. As a critical care paramedic, we work within a scope that we're given, and we have the people who are at the scene. It may be a couple of paramedics. It may be we even may have some family members that we could instruct to do certain things. So a part of being a CCP is that we need to thinking and forward planning. We need to be very clear and concise in our instructions, and we need to stay very calm in an emergency. So that's just some of the strengths that we need to bring to this style of emergency. We'll assign paramedics a role, knowing that if shoulder dystocia does become an emergency, then we have a baby being born and we have the mother to look after, and obviously all the other people around at the same time. So it's important we look after them as well. So shoulder dystocia is a complication that occurs during vaginal delivery. It is an obstetric emergency. Shoulder dystocia is caused by the impaction of the anterior or the posterior shoulder during a vaginal birth. Risk factors for shoulder dystocia include diabetes mellitus, maternal obesity, fetal macrosomia, prolonged first and second stage of labour, gestational age of more than 42 weeks, previous shoulder dystocia. Nearly 50% of all shoulder dystocia cases are not predictable, don't have any risk factors at all. We need to be prepared for the possibility of the shoulder dystocia at any out-of-hospital delivery. Complications of shoulder dystocia to the fetus: brachial plexus injuries, neonatal fractures, hypoxia and stillbirths, and maternal trauma. So the diagnosis: a vaginal cephalic birth that requires additional manoeuvres to assist the birth of the baby's shoulders after the head has been born and gentle diagnostic tractions have failed. It is crucial to diagnose shoulder dystocia as soon as it occurs to effectively reduce neonatal hypoxia and injury. The goal of management is to deliver the infant without asphyxia from umbilical cord compression, without causing any fetal or maternal trauma. So the key principles and what we're trying to do is to increase the functional size of the bony pelvis and to change the bisacral diameter by rotating the fetus into a wider oblique diameter. Warning signs: slow and difficult labours, chin retraction, which we call the turtle sign, fetal head remains tightly applied to the vulva, and routine traction fails to deliver the shoulder. I'll then videotape my manoeuvre skills, and add them to this video clip.
It's Paul Grant here, and today we're going to go through the management of shoulder dystocia, which is my topic for this assessment. So a couple of things before we start is that this is an out-of-hospital environment, so a lot of the mnemonics that we use are not really relevant to an out-of-hospital environment, especially when we're calling for help. The people who are there at that moment are going to be our help. The other help that we can do, obviously, is call ahead and let a receiving facility know what's going on. We've now gone through the second stage of labour, and actively now the head is birthed, and we're now seeing that we've got either possible turtle sign, which is the head's coming in and out because it's not getting through the birthing channel, or that again the face could be stuck against the vulva really closely. So straight away we need to call that this is an obstetric emergency, and we now get our assistant and our help to come in and start to assist. So going through our mnemonic, H is for help, and as I said before, we'll only have the people that are here, but we could call ahead. E is for evaluation. We can look at, and really a part of a paramedic scope isn't really to look and do an episiotomy, but under the directions of a medical officer, then that could be something that we can evaluate. L is for legs. And what we're going to do, besides doing just routine axial traction, which there's no movement, then we'll go into Robert's position. We'd pull the mother down to the end of the bed. We would then pull the thighs forward, and I would get one of the paramedics on each side to then lift and push back. And what this does is it creates an anterior movement of the pelvis, and it actually, at the sacrum, it flattens out the sacrum, which will then increase that diameter, the bisacromial diameter of the pelvis. Lots of times this movement will then allow this baby to be born correctly. You know, if we then have that recognition that this hasn't happened, we'll go into suprapubic pressure, and then I'll get one of the paramedics then to, similar to a CPR hand. Okay? And when we obviously don't need it on the surface pubis, we need it to then just to push the shoulder into the oblique position, which will allow then the baby to be born as such. But we won't do the full birth there. We'll put him back. Okay, so again, the shoulder is stuck up, symphysis pubis. We've now tried normal axial traction, diagnostic traction, and we can also rock that movement as well. So we may start with 30 seconds of just trying to move, and then maybe another 30 seconds of trying to rock. If that doesn't work, then we're starting to get into some more internal movements. Okay, so the first internal movement is, we start off with Rubin's Maneuver 1, trying to get to the shoulder and just rotating that shoulder, that anterior shoulder, into a position where now the baby can be birthed. Okay, that's one. Two is that then we can go in and attempt to sweep the arm, and you would do this from posteriorly. And again, this is where it's really good if you had a paramedic who had a small hand, of trying to reach through, grabbing the arm and trying to sweep that. And we find the arm. That's it. And again, we're just going to straighten that arm right up, and then the baby's born. So the next movement, if that doesn't work, and usually you'll wait about 30 seconds. If you can't manage one technique within 30 seconds, you want to move on to the next technique. So from there, what we're going to now do is what we call a wood screw movement. We're going to reach in to the posterior of the anterior shoulder, and again push that into the oblique position, and again birth the baby. If that in 30 seconds is again unsuccessful, okay, so again going back to the wood screw, if you find that one direction you wouldn't be able to move that shoulder, then we'll go from posterior, or the anterior and posterior, and be pushing in opposite ways to then getting from the posterior to the anterior, and again screwing one way. And if that didn't work, then you would then go back and do the reverse wood screw from the other way, anterior, posterior, and pushing, and again wood screw, trying to screw the baby into that oblique position, where again we can do axial traction, normal axial traction, and birth the baby, putting the mother onto all fours, and going back and repeating those same movements. The movements and techniques, moving from one to the next to the next. Baby's born. We'll then pass that off to the paramedic to then look after the baby. Before a minute's up, go into evaluating for an APGAR score, so to create a baseline, and then 5 minutes later. So then that's important for us to then pass on to the receiving facility, and the other person would be definitely documenting the times and minutes, how long it's taken, how quickly we move through these procedures.
We can now put the whole package together, running through a scenario paramedics and a CCP are called to an obstetric emergency. quickly recognised shoulder dystocia, go through our systematic approach to shoulder dystocia. Once the baby is born, then we need to monitor the baby and the mother. Third stage of labour, possible complications. So best place to be is at definitive care. You may even delay clamping the cord. The third stage of labour may be, sort of extended. So let's get them to where they need to be, slow and steady. Everyone understands their roles, and let's have a successful delivery of shoulder dystocia case. And now get them back to definitive care. Thank you.